Well, there's definitely something you experience when you go through something like this. It's almost like you're living a dream. It's like a surreal dream almost. And you're just wondering when you're going to wake up. Come on, let's go tight. Come on. Let's go tight. No bark. Hey. No bark. Ugh. Yeah. And I got no sleep.
Yeah, I'm feeding them. Yeah.
You make sure to give them fresh water.
Yeah. Okay.
Should really try and
Taste your food sometime.
park there. It's all that parking lot right there. So I just got injected with some bone scan injector fluid. I don't know. I could be glowing right now. Who knows? But it's 7:30 right now, and we need to wait until 9:15 to talk to the doctor. So we're gonna be sitting here for a little while. And just doing a little work. So yeah, maybe I'll take an hour nap or something. So. But after talking to the doctor, we're gonna head back down where they injected me to scan my entire body. So should be fun.
The idea is just to make sure the first thing we're doing today
Yeah.
is make sure that there's not anything else going on.
Okay.
Okay, we kind of talked about this on Friday.
Yeah.
It's very unlikely, okay, but we have to check because every one of those things determines kind of what we do next.
Sure.
There's a lot of little pieces of a puzzle to put together.
It makes sense.
So, so that's one thing. Okay, you're going to meet with Dr. Rose sometime today. He's not scheduled to be seeing patients, but he's going to kind of we're going to try and get you two together so you can sit down and talk to him. He's an orthopedic cancer specialist. Okay, for lack of a better word. Okay. And what he specializes is in tumors that arise from bone. Okay. I specialize in spine surgery and tumors that arise from the spine. These tumors typically have more in common with tumors that people might get in the hip and in the leg or something like that. And those are a lot more common. So he knows a lot more about those than
Yeah.
me.
So you're working together.
Yeah, we're working together.
Yeah.
Okay, and so that's why you're going to meet him. And he already has outlined a couple of potential things that we may need to do
Okay.
in addition to this.
Okay.
So the other thing that's going to happen today is they're going to go ahead and get some special CT scans so we can make a model like this of what's going on with you.
Okay.
Okay? This is not you, but this is an example. This is
Yeah.
life size.
Sure.
Okay? And this is someone who had a tumor in a different location than you. But what this allows us to do is have a three-dimensional model
Yeah.
that we can use to plan out what's surgery you need. Okay?
Best course of action.
Okay, and so, and the basic principle here, okay, is a lot of tumors that I deal with, if there's a tumor, okay, you can just go in and basically break it up into small pieces, and take out the small pieces,
Yeah.
and you're done.
If it was an osteochondroma, right?
Something like
It
that,
was
or
not
some of the
cancer.
more typical things, okay?
Yeah.
This tumor is a little different. If this is the tumor, the best way to ensure getting it out without leaving anything behind
It's a one whole piece.
is to go around it as much as possible and take a small, and this is kind of an exaggeration, and take a small boundary of normal tissue.
Yeah.
Because then basically we're removing the tumor, we're not leaving anything behind.
Yeah.
We're actually going to take a little normal tissue with it. Now, in your case, there's some parts of it that go down into the spinal canal that we're probably going to have to take out as a little bit differently.
Yeah.
But that's the goal. And that's what kind of Dr. Rose is a real expert in, is figuring out the best way to get this done.
Okay.
Okay?
Yeah.
And for something like that, that's critical, I think.
Yeah.
And so that's why, rather than going in for me to do kind of a typical operation for one of these,
Yeah.
I'm having you see him, we're
Yeah.
doing a little bit more imaging, we're doing the bone scan, we're doing things like that. So that's that. And then he's right now, since all of this kind of came up on Friday,
Yeah.
he's right now he's over at Methodist. He works between Methodist and St. Mary's. He's going to ask one of our radiation specialists. There seems to be better outcomes with you getting proton beam radiation before surgery a little bit, and then doing the surgery, and then you getting it afterwards.
Yeah. And that kind of, was it kill the cancer?
Yeah, it kills it, it doesn't, it makes it a little bit more dormant when we go in. But the radiation oncologists here who specialize, and we have a group that specializes in these kind of tumors,
Yeah.
they give us their best advice on that. So he's actually talking to someone probably before he sees you at some point to determine what's what happens with that.
Sure.
And then I don't know if you have time over next to Methodist, you'll see this block long building.
Yeah.
That's the proton beam.
Okay.
Okay.
All right.
But so that's kind of where we're at.
Okay.
So today I looked at your schedule. You have a CT scan plan. You have the rest of the bone scan to complete and all that stuff.
Yeah.
And then we go from there.
Okay.
I mean, like I said on Friday, it's a serious thing, but it's not. It just changes our game plan a little bit.
Okay.
Okay.
All right.
Um,
You said this is the lowest level?
This is lowest. So chondrosarcoma comes
Yeah.
in 3 grades: grade 1, grade 2, and grade 3.
Okay.
Grade three is the worst. Grade 1 is the best.
Okay.
If none of them can be best,
Yeah,
but
they're
it's
just-
better.
yeah,
It's
yeah.
better. The problem, and if you don't do a good resection, the grade 1s will come back as a grade 2, and then eventually will be a grade 3.
Okay.
And so our goal is to treat it correctly up front,
Especially with the proton beam.
and do that. And
Yeah.
so that's kind of where we're at. As things go this week, plans will start coming together,
Yeah.
and we'll have everything. But we just need a little bit more information.
Sure.
I kind of want you to meet Dr. Rose,
Okay.
so you get to meet, and it's just going to be me and him probably taking care of this,
Yeah.
and we'll go from there.
Because chemo and radiation doesn't work with this type of cancer, right?
Radiation does.
It does.
Proton beam there seems to be even better experience with proton beam, but radiation does. But chemo, not typically.
Okay.
Okay, not typically. And Dr. Rose is much more familiar with the current non-surgical treatment for these things, and that's why that's another reason he's involved.
Okay. So this proton beam thing, there's only a select few of these, huh?
There's about a dozen of them in the country.
Okay.
I don't think there's another one in the state of Minnesota.
Okay.
I don't think there's one in the state of Wisconsin. I know there's probably one in Illinois.
And that just like pinpoints.
No, it basically uses protons rather than, most radiation uses electrons.
Okay.
Basically shoots electrons and stuff.
Okay.
Radiation.
Okay.
This shoots protons.
Okay.
So this basically shoots stripped down water molecules and stuff.
Okay.
The advantage is they're heavier, they do a lot more damage, they don't spread as far. It's been very successful in the treatment of some sarcomas.
Okay. Now, so far, do you guys think that there's a possibility that you might have to fuse my neck?
You're going to need a fusion.
Okay.
Okay, because the problem is that the bone involvement. We'll see this better with the to get this one margin. I think on the right side, it's going to require taking down the joint.
Okay.
Okay,
Yeah.
and once we take down one joint, it completely to get that margin, we're obligated to fusion. This is actually what a fusion looks
Yeah.
like up here.
How many of the vertebrae do you think will have to be fused?
Usually we'll go 2 above, 2 below.
Okay.
But it depends. The model will help determine that. I mean, we only really need to fuse where we're going to destabilize and where we're going to remove bone. If we only do that at one segment, then you only need it over that segment.
Now, does that severely limit my ability to...
Shouldn't down at this level.
Okay.
Shouldn't.
Okay.
This kind of movement, not even remotely related to where your tumor is located.
Okay.
This kind of movement, slightly, but very slightly.
Okay.
So,
Okay. Okay. All right. Yeah. Hey, I know you got a lot of planning to do, but just a ballpark idea when you think the surgery might take course. I know,
I'd like to get it done. I would think realistically next week.
Okay.
Realistically.
Yeah.
Okay. A lot of it depends on just if you need proton beam and they can work you in there, and then realistically next week.
Okay.
Okay. But I can't really say for sure because Dr. Rose and I need to coordinate schedules. He's going to be very flexible on this, but it's like I said. The earliest I'm thinking is next week.
Okay.
Okay. If there's potential to squeeze it in this week, we will.
Okay. All right.
Okay.
Sounds good.
Okay.
All right. Well, I appreciate your help so far.
And the model, I don't know how long it's going to take them to make the model, but the model, we found with this, we don't do these for everything.
Yeah.
For these, we find, see, on this model, this is pretty complicated. This has nothing, this is much more complicated than your situation, but this is tumor out the front, and this just helps us to look at it and visualize and say, okay, we need to come down here, we need to come down here. And we'll be able to show that model to you once it's done.
Okay. All right.
So,
Well, that'll help explain a lot. So.
yeah.
Okay, good.
It's a lot to digest. I understand that.
It is, but I'm past the shock and awe. I'm like to the point where I'm like, I want to get this over with. Was there anything else that you can think of we need to talk about?
Well, not now. I think we've covered it between today and the last conversation we had. Questions are going to come up as we move forward, so just save them and we'll get to them as we can, okay?
So when you're preliminary wise, you're thinking when the surgery actually happens, you'll have how many actual different specialty doctors?
Just me and Rose.
Okay. All right.
Just me and Rose. I don't see anything else. This is all posterior. We're not dealing with anything up front. Doesn't seem to be involving any of the vascular tree up there, so we don't need anybody for that. And it really is just bone and nerves.
I feel really good. I feel strong as an ox. As long as I don't start moving my arm too much. So.
Yeah, good. Yeah, I think we have a little bit of time, and I think even with if you need preoperative radiation, that's going to probably hit this thing pretty well too. So, but that, like I said, there's different treatment pathways that have been developed for each one of these based on the tumor type and grade.
Yeah.
And so for and this is the advantage of having Dr. Rose involved is that I didn't even know at this point that we were using preoperative proton beam for these. I thought we were typically doing it postoperatively, but that would help.
So do you think it started as an osteochondroma and then turned into chondrosarcoma?
Yeah.
Actually, Dr. Carlson has been communicating about him.
You think it's more like genetic, or do you think I did have a nasty snowboard accident? Do you think that might have caused it? It just started as... Okay.
So basically, most of these things are a chromosome and one cell gets damaged.
And then, if you had to take a wild guess, how old do you think that tumor is?
A couple years.
Really?
Yeah, Rose can tell you about her. He's seen a lot more seen a lot more chondrosarcomas than I in a lot of different spots, and he can tell you.
It's a pretty rare tumor, though, right?
It's extremely rare.
You know, like how many, like, out of cases a year?
Well, the last set of
It's
CTs,
you know,
I
we
think, is gonna
usually
be-
we don't
it's
think in
one
those
where
terms. I
it's
mean, it's
for
like
Dr.
how many
Hudson
per
to
100,000
make
people?
a
Yeah.
spine
Probably
model
less than one
for the surgery,
Wow.
per
the very
100,000
last
people.
set. So I don't
Right.
know if that's gonna make a difference.
So.
Well, I'm glad we caught it when we did.
Because he's
Yeah.
already had
Yeah,
regular
I think no, we caught it
CTs.
just about.
Well,
You know, we caught it. I
guess it
think
would be
as
helpful
early as we
to
could.
know about the
Okay.
chest CT.
Well, that sounds good.
All right.
Thank you.
But Dr. Krause sent me a note that
That's wild. Bone scanner, huh? Head to toe. Okay, so we got this done. Got the bone scan done. Now they just called and said they want to move my meeting with Rose to 12, so this is no good anymore. So they gave me a whole new schedule. So, I gotta hand it to them though. They're pretty organized here, so and they make it pretty easy once you get the hang of what's going on around here in terms between the different buildings and such. So, so I got another meeting with another doctor that's gonna be helping Kraus during the surgery, and then I got 2 more CT scans, and then I'm done for the day. And they just called, and they potentially might want me to come back tomorrow to meet this guy, just to talk to him. So I'm gonna see if I can just do this over the phone. And pager's going. So this is the meeting with the orthopedic surgeon that's gonna help Kraus out during the surgery.
How'd you find it?
I was having pain in my right shoulder. I thought it was a shoulder cuff injury.
Okay.
And so I went and had an x-ray done on my right shoulder.
Yeah.
And that was at the Mayo of
Eau
Eau
Claire,
Claire
right?
with Tom.
Okay.
And he, you know, we looked at the shoulder and everything, and he's like, I don't see any bone spurs. Everything looks great.
And we figured out something's in your neck pressed on.
And then I just went on my merry way, and not even the x-ray tech caught it. And so I went to a chiropractor, Active Health Care with Dr. John, had them forward that x-ray from Mayo to him, and then he caught it. And he's like, Todd, there's something seriously wrong with your neck. You got to go back and get an x-ray done at your neck ASAP. So,
Right there on the very
Yeah.
edge of it there.
yeah, and then that's when I went back and got the x-ray of my neck, and then at that point we realized what was going on. So.
Are things getting better, getting worse, or just not going away?
I feel amazing. I stopped ever since I stopped working. All the pain went completely away. So the pain was right underneath my right shoulder blade.
C-spine model.
So and then you know, the more I work, the harder I work, the pain would just creep down my arm. And then I started getting tingling in my.
What sort of work do you do?
I'm an estimator. I stare at blueprints all day. You know,
Sure.
not a calculator, nonstop. So.
Okay. All right. Well, we've come to understand that
you have this tumor which is there, and we'll go over just where it is on your scans on the model. And we've also come to understand it to be what we call a low-grade chondrosarcoma. And so we'll talk about what that means and what different options. I know you saw Dr. Krause earlier today. He's one of the neurosurgeons who deals with things all around the spine.
Yeah.
I'm one of the tumor surgeons, and so I deal with bone tumors all around the body. And oftentimes we can work better on things if we work together.
Yeah.
The truth is I deal with chondrosarcomas last week in the ribs, the week before in the leg and such.
Yeah.
He's an absolute expert of this area of the spine. I do work in the spine as well, but Dr. Krause is an absolute expert in this area of the
Yeah.
spine. And let me just begin to pull up some of these things right here. For your CAT scan and for your MRI scan right here. Okay, so all right. So what we're going to look at here is we're going to look as if we're looking in at you from the side. Okay. So
Yeah.
this is your jaw right
Yeah.
here. This is the base of your brain. Looking at you from the side. This particular sequence is programmed to wash out everything but your nerves and the tumor. Okay? So this sort of gray ribbon coming down here are the nerves of your spinal cord.
Okay.
This white halo which goes around that is the fluid which bathes the nerves.
Yeah.
So if you've ever heard of someone having a spinal anesthetic, that's when you inject medicine into the fluid,
Okay.
it flows around the nerves and numbs them up.
Okay.
When somebody has meningitis, that's an infection of that fluid,
Okay.
just for reference. Okay. And then all of this thing right here in the back, this is the tumor right here. And what's particularly noteworthy about the tumor is that it goes in, see how it's pressing in by the nerves of the spinal cord right there.
Yeah.
It's pressing in more upon the right side, which is why you're having that pain
Yeah.
and the weakness and such on the right side
Yeah.
of things. So,
I really don't have any weakness. It's just pain.
okay, so this is just a model of your neck, just to show you, so the back of your head right here. So this is as if we're looking at things like this for you.
Mm-hmm.
And we're looking at stuff that's kind of right about this right here for you, okay? This is kind of where we are
Okay.
with things. Now, take a picture of that.
Yeah,
if you need to.
it's video.
Oh, that's right, I'm sorry. Yeah. I would like to check a few things on you,
Okay.
if I don't mind here. Can you squeeze as tight as you can? Okay, so that's great. Fingers wide, hold them strong. I know everyone keeps doing this to you. Wrist back real strong. That's good. Wrist straight down. That's good. Arms like this. Push me away strongly and pull me back toward you. So all of it's good for you. Obviously your legs are working well.
Yeah, but the only thing I have right now is a tingling sensation in my feet.
Okay. Just relax right here for me. Okay. So let's talk about chondrosarcoma. Chondrosarcoma is a relatively rare form of cancer where the cancer arises within the bones itself. So for reference, most cancers that we deal with come from the organs, liver cancer, lung cancer, kidney cancer, breast cancer,
Yeah.
or from the blood elements, leukemia, lymphoma, myeloma, things like that. Chondrosarcomas are where the cancer arises directly from the bone. There are a couple hundred total per year in the United States each year.
So it's super rare.
So it's a relatively rare thing. And what we know about yours is it's what we call a low-grade chondrosarcoma. And that's actually very favorable for you. If you have to have this, you'd much rather have something which is low-grade than something which is high-grade. Now the difficulty comes when we think about chondrosarcomas. Part of their intrinsic characteristic is that even when they look as if they've got a nice sharp boundary around them, on a microscopic basis, too small for us to see with our eyes, or even for our scans to see fully, these tumors can have what we call little tentacles that come away from them, or even little satellites. Now, the way that we tend to this, if it's in your knee, the truth is you generally get the world's biggest knee replacement. We take it out in a big fashion.
Mhm.
We call a wide resection around the areas. So we take the tumor out with a cuff of normal tissue around it, and then deal with whatever we need to put in afterwards.
Mhm.
Okay? The trouble comes where yours is. So let's look at your MRI scan again. And we're going to change the machine so it turns your neck into sort of a loaf of bread, okay?
Okay.
And it's going to start at the bottom, it's going to make a loaf of bread slices going up. And this is a nice example. This is as if we're looking kind of right like this, actually,
Mhm.
okay? So we've got the bone in the front, the bone in the back,
Yeah.
the bone in the front, bone in the back. And then the nerves right here. And again, the gray oval are the nerves of the spinal cord.
Yeah.
And the white is the fluid that bathes. Okay, so that's how we are right here.
Okay.
Now, if we march our way up here, what we're going to see is we start to see tumor there, but more so as we see it come to pass here, we see the tumor
It's
enters in and it's pressing on things. So then if we look at this picture,
Yeah.
all of a sudden now we're looking at something that's a lot more like this right here.
Yeah.
And the trouble is that with it pressing hard on the nerves there, the idea of taking it out in a big wide fashion like this,
Yeah, it's
well,
very difficult.
well, the trouble is honestly your spinal cord's right there.
Yeah.
And so we lack an ability to take it out in a truly wide fashion here for you. So, what do? We need to do something to try to make up for that. Now, when chondrosarcomas occur in these locations, they can be very, very vexing to deal with, because if you take it out but you necessarily aren't widely around it, or you have to come through the tumor in a controlled way but you're still going through the tumor,
Yeah.
then you worry that you leave cells behind, and the likelihood of tumor coming back is extremely high. When it comes back, the recurrence is usually in a manner that's very unpredictable and can be associated with the tumor coming back more aggressively and in a way that can be very difficult to treat for you.
Okay.
So what do we do in this scenario? The first thing, whenever we diagnose anybody with a cancer, is we sort of check out other things. So you've got your bone scan, which they'll be processing. You're going to get your CAT scan of your chest this afternoon, because we always check to be sure there's no evidence of tumor in another bone. That's what
Mhm.
the bone scan looks at.
Yeah.
Or in your lungs. With a low-grade chondrosarcoma, that likelihood is quite low, but the truth is we need to look and we need a baseline exam on you.
Yeah.
Then we've got to figure out what's our best way that we deal with this for you, understanding that we can't take it out in the wide fashion that we'd like to.
Yeah.
So when we're faced with that, we've learned to consider to employ some pretty advanced forms of radiation in this setting. Now, most typically, chondrosarcoma is not treated with radiation because chondrosarcoma generally isn't sensitive to radiation at the doses that we can usually achieve for it.
Yeah.
So if you hit anything hard enough with radiation, you can kill anything with radiation. But we're never limited by the dose that we give to the cancer. We're always limited by what is the scatter dose to the surrounding tissues, or for lack of a better term, frankly, the innocent bystander effect.
Yeah.
And so our ability to treat things, or to frankly put dose on target with radiation, which is what it's about, has to do very heavily with the precision of things. I spoke this morning with one of our folks who does proton beam therapy here, and she would like to visit with you tomorrow. Your schedule's pretty full today.
Yeah.
But she can visit with you tomorrow in the afternoon with things, because as we look toward treating this for you, we're worried that we may not be able to get all the seeds, and that in some way we're probably going to have to split the tumor to get it out, and in doing so more seeds can spill out.
Mm-hmm.
Now, in this setting, radiation, you can think of radiation a little bit like Roundup, if you will. And what I mean by that is that a few squirts of Roundup on a tree isn't going to kill the tree. It's not particularly healthy for the tree, but it's not going to kill it. We can't kill this tumor for you with radiation alone because we can't achieve an adequate dose on it. But we can take out everything we can see there, but we're really worried about the seeds that we can't access in this setting. And in that regard, radiation can play a very strong role in killing the seeds, because just as Roundup won't do much good to a full-grown tree,
Mm-hmm.
but if you have a tiny seed that's starting to go and you spray that stuff on it, you're fine.
Yeah.
The weed in your sidewalk is done.
Yeah.
That's how we look at radiation for
Okay.
this. Now, there's not as much data in using this because our ability to have radiation in this precise a manner is something which has really advanced just in the last several years dramatically with things. But what information we have lets us know that this is probably our best way to treat this for you.
Okay.
So in summary, what we think about is, first of all, you're in the process of what we call staging. Staging is to define exactly where the tumor is and where it isn't.
Yeah.
That's part one. The second, we're going to need to do surgery for this for you because we need to take out the bulk tumor in every way.
Yeah.
Dr. Krause and I can work together to do that. That's no problem at all. But thirdly, we've got to keep in mind if we don't prepare to do something to think about these little seeds,
Yeah.
there's a very high likelihood that this comes back. And when it comes back, it doesn't play out well. We're far better to look to treat this
Sure.
for. Now, what that's probably going to look like from your perspective, it's probably going to look like a recommendation to have radiation initially as a lead into surgery to sort of kind of knock them over,
Yeah.
make them stunned. Have an operation, recover for several weeks from that operation, and then
Okay.
have additional radiation as well.
Okay.
There are times we even consider the role of radiation in surgery. That becomes a little bit of a nuanced thing that Dr. Peterson is sort of an expert on as to whether or not she thinks would be best for you.
Yeah.
But just to let you know what we'd recommend for that. That's, of course, the radiation is most commonly done once a day. The lead-in radiation is usually over the course of 2 to 3 weeks before an operation. Then there's surgery, then you recover from surgery, then you come back for further radiation, which is also usually a once-a-day type of thing. In fairness, they don't have the technical capabilities to do that in Eau Claire, so this would probably be a Rochester type
Yeah, I
thing.
hear
Just
you.
so you
Yeah,
understand,
yeah.
Eau Claire's a great place,
Yeah.
but we've
No, we're getting used to driving here.
yeah,
So.
so we're fortunate to have this, and I think that's what I'd say, sir. And we could. I'm sorry you have this trouble, but if you've got it, we need to get on it for you.
Yeah.
Okay.
All right.
Does all that make sense?
That makes total sense.
Okay. So I wanted to have a chance to visit with you just because the rest of my week is likely to be tied up with some other stuff, but I didn't want to have a chance to not visit with you
Sure.
about this ahead of
Yeah.
time. Dr. Krause and I had been in communication. He was out of town over the weekend. I knew that you were seeing him this morning,
Yeah.
and so I figured I'd visit with you after you saw him, just so you get the perspective, and we'll work as a team for this for you.
Okay. Sounds good.
Okay.
So, all right. If you had to take a guess, how old do you think that tumor is?
It's really, I don't think it's growing leaps and bounds on it. My suspicion is that this probably, you probably had a little what we call a precursor lesion there, which we can see, they show up in people. Sort of like a polyp in your colon or,
Yeah.
a cyst in your breast or something. It was fine, and then it just kind of cooked off, if you will. And so, but I think it's been growing slowly for you. And I say that because I don't see a lot of swelling in the tissues around it. If a tumor grows very quickly,
Mm-hmm.
it will cause the tissues around it to swell as they respond to the tumor growing so rapidly. I don't see any evidence of any of those things for you. So I think this has probably been slowly growing for you. And the issue is, this is the nerve, if you look right here.
Yeah.
See that?
Yeah.
That's the nerve that's about to exit, just as the nerves come out like this,
Yeah.
right? And then, bang, that's the tumor on it right there.
Okay.
And so, as a young, healthy guy, you got lots of room for your nerves because you don't have much for arthritis in your neck.
No.
So you were fine, and what happened is if your arm is the nerve, the tumor is growing and everything's fine, and the tumor grows slowly and everything's fine, and then all of a sudden one day it's doing this, and you say, gosh, what's going on there?
Yeah.
That's what's happening
Yeah.
for you. But that's good in the sense that growing slowly also implies these are usually a little bit more of a pusher than an invader with things.
Yeah.
We still have this microscopic
Yeah.
little seed thing we've got to worry about, but more of a pusher than an invader for
Okay.
you.
So what happens to that void after they
Yeah.
take all that out?
You're exactly right. There's an empty space or a gap of flesh, frankly, when this is done. And to heal up reliably from this, you'll need something to help to fill that empty space. And so, not to get too far down the line, but we'll probably have one of our plastic surgeons available to help to transfer. You've got a number of different muscles all around your back there. And there can be a role to take one of those muscles and slide it further over and transfer it into that area to help fill the empty space or void, which can make healing more reliable after surgery. Because otherwise, like you say, there's a big empty space and a void
Yeah.
there for you.
Yeah. Okay. All right. Sounds
Okay.
super complicated.
No, listen, it is not a straightforward thing. I'd be very open with you about it, but it's also the type of stuff that we tackle. There are going to be some ups and downs and some uncertainties along the way, but most importantly, now we understand what's going on.
Yeah.
Because if you don't understand what's going on, then one, this thing can grow to the point that it becomes a critical issue and much riskier for you.
Yeah.
And the second is, if we understand ahead of time, then we can make plans. So I know, for example, that you had a tentative surgery set today, and obviously the plug got pulled on that
Yeah.
for the right reasons.
Yeah.
Because that was tentative until they got the biopsy result
Sure.
back. And once the biopsy showed it was something different, the answer is just to stop.
Yeah.
Just to stop,
Yeah.
because what you don't want to do is forge ahead when things need more treatment ahead of time.
Exactly.
So.
Yeah. Okay. I guess I don't really have any other questions other than
I think we'll finish up what's called your staging, which is your CAT scan and such this afternoon. We're actually going to have our team make a three-dimensional model of your neck. So for better for worse, honestly,
Yeah.
we've got a 3D printer, and we print out models of these things.
yeah.
That allow us to simulate different surgical approaches, so we
Okay.
can see what's the best way to get around this team.
Okay.
And also, we've got more than one person on the team, so everyone on the team can sit down and go over the plan ahead of time. And
Yeah.
so we're not making it up as we go along,
Sure.
frankly. And so the other thing is your CAT scan and such. We'll plan for that. I know that folks were looking at doing that, and it's possible they may need some slightly more images. I know the 3D modeling team was looking at things for you to see, are there any additional images that they need to get for you associated with this? And whatever we need, we can get for you to be sure things are played up. And I think you're set for that this afternoon as well.
Have you looked at the bone scan that was done today?
I haven't seen it yet because I think they're still processing stuff for you. So.
All right.
All right, sir.
So, all right.
Well, look, it's a pleasure to visit with you. I'm sorry to these circumstances,
Yeah,
but we can get to the bottom of this,
Yeah.
okay?
All right.
We're all going to work as a team, but there also can only be one captain of a ship, and that'll be Dr. Krause for you. And I
Yeah.
say that as a compliment to him, and just so you understand,
Yeah.
because otherwise, at the end of the day, someone's got to be in charge,
Yeah.
and you've got to know someone is your point person for contact.
Yeah.
I suspect that we're going to be obviously looking into a run-in with radiation ahead of this, and Dr. Peterson, who you'll meet tomorrow,
Yeah.
she would be your lead during that. But for kind of the overall orchestration of things, and certainly for the coordination around surgery, we'll let Dr. Krause run the team, and we'll be happy to be there for you. Okay?
But how do you think that radiation will? Maybe that's a question to ask her. I guess.
It's to sterilize the seeds.
Yeah, but
That's
I
the
mean,
idea.
the affect my spine.
You know, the issue of being very, very precise is helpful because we think about your spine and everything around there as
Yeah.
kind of part of the innocent bystander mode.
Yeah.
I can't tell you that there's going to be no effect on it, but what I can tell you is the overwhelming effect is going to be beneficial to treat
Yeah.
the cancer.
Yeah.
And the other effect is going to be modest because of their ability to hold the beam in pretty tight tolerances.
Okay. Like you said, they might actually do it during the surgery too.
Yeah, we have capabilities for that in a way if we need to. So.
All right.
Okay. All right, sir.
Thank you. Man, I gotta get my shoes off. They're driving me crazy. Feet are way tingling. I've been successfully radiated from head to toe once today, 2 more times. Turn into the Incredible Hulk, I think. So I'm gonna get both CT scans done right away. It's all about waiting. Thanks.
Going to eat.
Successfully radiated head to toe 3 times. Man,
Oh my god.
had a full body bone scan, every single bone in my body, and then 2 separate CT scans, one of my spine and one of my chest. So I think I've been thoroughly poked and prodded for the day. How hungry are you?
could eat the balls off a skunk. So hungry.
Let's go get some balls off a skunk.
I'd even eat liver and onion.
Thank God that's over with.
Yeah.
What a day, huh?
It's been a long day.
Jeez. I don't turn into the Incredible Hulk. After being hit with so many gamma rays. I don't know why. All right, 2:30. We got to come back tomorrow.
Yeah.
Isn't that awesome?
Yeah.
Well, it's Tuesday morning, 25th, and we just drove 2 hours to talk to somebody.
So let me kind of briefly recap what I know about you is that for the last about year and a half, you've been having right shoulder pain.
Yeah, a year and a half. Pain started in my right shoulder, and then starting about 6 months ago, it started creeping down my arm.
Okay.
And then about 2 months ago, I started getting a tingling sensation all the way up to my finger here.
Okay.
And about 2 to 3 weeks ago, maybe 4 weeks, I started getting a tingling sensation in my right foot.
Okay, 2 to 3 weeks ago.
Yeah, and then, but that's when I was working, 50 hours a week.
Okay.
And then about 2 weeks ago, I started getting tingling sensation in both feet. But ever since I quit work about 2.5 weeks ago, it's all gone. I mean, I have no pain, no tingling. I feel
the shoulder pain is gone and
everything. I mean, I feel 100% right now. So.
Wow. That's kind of strange, isn't it?
Yeah, well, if I was to do any manual labor, anything that, if I had to move this arm for more than a half hour, it would instantly just rock it right down my arm.
Okay.
So,
So even in that 2 weeks, you've done a little bit of work and you've noticed that.
Oh yeah.
Okay.
I've literally just stopped anything repetitious. I'm on 2 months of leave from work, and I've been eating like super healthy, and that's helped more than anything. So
just look at the calendar here. So I also note that Dr. I can't her name, neurologist, put you on some dexamethasone.
Yeah.
Was the timing of this change in
Yes.
numbness consistent with that or not?
I had tingling, a little bit of tingling in both feet, more on my right foot. It was very slight, but the second I started using that dexamethasone or whatever, it made it way worse.
Oh.
And didn't it? And it made me really edgy. And I even asked my doctor, Kraus.
Okay.
Yeah,
surgeon,
I'm like, can I just not take that? Or he cut me half a way back on it.
Okay.
It's an anti-inflammatory.
No, it's more than an anti-inflammatory. It's a very strong steroid. So you're taking one pill once a day now, then, instead of twice a day?
They wanted me to do one in the morning and one at night.
Right.
And I'm like, it was driving my feet crazy.
Okay.
And I'm like,
Right. So now you're taking just
so
one in the
now
morning?
I'm doing a half in the morning and half at night.
Oh, okay, half. Okay. I'll tell you what I'm going to do. I know you met with Dr. Rose yesterday, and my guess is you didn't talk about this at all because I noticed that she put you on the dexamethasone to see whether we need to continue it at all.
I for a couple days, I stopped taking it. I felt like $1 million.
Okay. Let me just check with him. I don't have any problem with that because this process has clearly been around for a long time. I know Dr. Hammock, I'm trying to remember.
Yeah.
So I think that, she thought this was like emergent and that was, impending problem, but it clearly isn't. It's something that's been emerging gradually over a long period of time. So it's not the same as a patient who has a sudden onset of problems.
The first night I took it, it was, remember, how bad it was? I'm like,
Probably
my
didn't sleep,
feet
but-
are going nuts.
Yeah. Okay.
And it's like massive tingling was going through both my feet. And so it got better. I was still taking it. And then I'm like, I got to stop taking this. So I stopped taking it for, I think it was like a day. And instantly it got better.
Okay.
So.
Let me just check with them. I am pretty confident that we can stop the medication, but I think I just need to touch base with Dr. Rose to be sure he's comfortable with that. Okay. So a progressive pain and tingling problem over a year and a half, especially over the last 6 months.
Yeah.
In synopsis, you saw an orthopedic surgeon in Eau Claire in early September. They did an X-ray of your shoulder.
Yeah, he did. I went in there because I thought it was a shoulder cuff injury.
Right. Yeah.
So I did an X-ray. They didn't catch it, neither did the X-ray tech, because you could just barely catch the
Oh
tumor.
yeah, you can see it on the.
And
yeah.
so I'm like, okay, well, I may go to a chiropractor maybe. So I had them forward that X-ray to a chiropractor in town,
Okay.
and then that chiropractor says, Todd, you got to get in here ASAP. There's something on your X-ray that you need to see. So
Yeah.
I went in there, and he pinpointed it as like, there's nothing I can do for you. I don't know exactly what it is, but you need to get an X-ray of your neck right now.
Right.
And that's where the ball started rolling.
Right. And so then you can have that C-spine X-ray, and then shortly after that, I know you saw a neurosurgeon over. in
Yeah,
Eau
and then at
Claire.
that point we knew it was a tumor.
Yeah.
So.
And then since then you've had MRI scan and you've had
Yeah.
a CT scan
A
now.
whole body scan yesterday,
Yeah.
bone scan or whatever.
Okay.
so.
Yeah. Okay. So other than that.
Yeah, yesterday I had the whole body bone scan, a CT scan of my spine for this mold they're gonna make.
Right. Right.
And
yeah.
then they did they put dye and did my chest.
Okay. And other than this problem, it sounds like you've been otherwise pretty healthy. Is that correct?
Yeah,
I couldn't find anything else saying you had any other.
I had my
health problems.
appendix taken out.
Okay.
That was it.
That's it. Okay.
So
Wow. Wonderful. Good for you. And so currently, no numbness, no tingling, no strength problems.
no, I could bench press 250 pounds right now.
Let's not try it, okay? and I've read their thoughts, and actually Dr. Rose came down and talked to me about you yesterday. But kind of tell me in your own words what you understand about what this tumor is and what needs to be done, just so I kind of hear it from you and have.
Well, so far what I've been told, it's a chondrosarcoma. And it's, it's the grade 1 level of it, and it is cancerous, and they can try and take it out as best as they possibly can, and there's obviously the potential of leaving particles behind that hopefully this treatment will take care of it.
Okay. Okay,
So-
good. So chondrosarcomas, as you probably already have figured out, is pretty rare tumors.
Yeah.
Most people probably have never even heard of sarcomas, let alone chondrosarcomas. They create cartilage, and that's why you can see it on the X-ray that it looks like a bony
Mhm.
component, has a white appearance on a regular X-ray, and the treatment, without a doubt, in most locations of the body of these tumors is surgery. Okay. And surgery in an ideal situation when you have a sarcoma of any time is removing the tumor plus some normal tissue around that. And that, as you can obviously figure out, is physically impossible in this
Yeah,
location because your spinal canal
Yeah, you just can't
is
move
right.
my spine. Yeah,
No, well, you can, but it would not be compatible with good life.
yeah
So-
I want to move my arms.
there
and
we go.
legs.
Exactly. So we know that the surgery is already going to be what we would call marginal, meaning you're going to get it right at the edge. You're going to be right to the edge. And it's going to be, and as you know, it's already kind of pushing on the spinal cord, or the dura of the spinal cord. So the spinal canal, instead of being normally round, is kind of pushed in by this tumor.
Yeah.
So we know that that's the kind of resection. And the other thing that I think Dr. Rose is also concerned about is the fact that there's a lot of soft tissue extension
Yeah.
as well. And so the potential for what we would call contamination out into
Yeah,
that soft
there's like
tissue.
little fingers, little microscopic fingers.
So one of the things, there are chondrosarcomas that arise in places like this that radiation is used for. One of the most common places that it's published on is when these arise in what's called the base of skull, so way up at the top of the spinal canal, right up next to the
Yeah,
brain.
which you've seen before.
No, I haven't, but we'll get to that in a second. And well, I shouldn't say I haven't. I haven't in a long time. That location is even more difficult because surgery is that
Yeah.
much more difficult because of the brain. So, but when we see them in the spine themselves, we often have this kind of situation where we know the surgery is not going to be an optimal surgery, and then radiation is combined with the surgery to try to optimize control
Yeah.
of the tumor. Now, so what we have done in our practice, and is just purely based on, geography, is we've kind of elected that tumors that arise kind of in the high neck and the base of skull go to a different set of my colleagues.
Okay.
So and then things from here down are kind of in my territory.
Yeah.
So when I say I haven't seen one up there, I mean,
Yeah.
I haven't because they go to a different group of people. Okay,
Yeah, because
so
mine's right at the lower base of the cervical spine.
right. So I've seen ones that arise in the thoracic spine and in the back, the low spine, that type of thing. Or those are the ones that I see.
Mhm.
It's just an artificial division.
And they were chondrosarcomas.
Yep. So, and so most of the, I should say, the best experience with treating these is by using a combination of surgery and radiation, if you can. And I think that is possible. Dr. Rose, when I talked to him yesterday, said he did think this was resectable, but it's going to be that marginal
Yeah.
resectomy we talked about. So he would like to add radiation to it to try to gain control of this because you're otherwise in good health
Yeah.
and you're young, and we want to be aggressive to be sure that you don't
Yes.
have to deal with this again.
So it doesn't come back.
Exactly.
Because he mentioned it would come back with force if it did.
Yeah, it can, and second time surgery is really bad. And the best experience that talks about this, I think, is with the use of what are called protons. And protons are a special form of radiation that's only available in more limited centers across the United States. It allows you to give a radiation dose while limiting dose to the normal structures.
Yeah.
So, for example, the radiation dose when you give a normal X-ray, just like your chest X-ray or
Yeah.
your shoulder X-ray, when you have the, good artist, the body, it's
Mhm.
terrible.
I hear you. It's-
The radiation goes essentially right through it.
Yeah.
With this form of radiation, with the protons, it has the ability to come in and kind of stop when you get to a certain point in the body, okay? And so
Like you can pinpoint it.
well, it's more than pinpointing. It's that the energy comes in and then it deposits the dose and stops.
Okay.
And so if this is the area you want to treat, you have the energy come in and
Yeah.
you deposit it all right there.
Yeah.
Now, when it comes in, it's depositing some dose as well. But you can see that beyond it, there's nothing.
Mhm.
So there's no dose beyond it.
Okay.
Why is that important? Well, we're talking about
spinal
the spine.
cord, yeah.
And we're talking about the things in front of it, such as your vocal cords and your neck muscles and all those things, to try to minimize the dose to those structures and then lower down because it's right at the junction of your cervical and thoracic spine.
Yeah.
Things like your lungs, the upper part of your lungs,
Yeah.
and try to minimize the dose to those as well. So it allows you to do that. And especially when you're talking about the spinal cord that's going to be in the vicinity, it's one of the things that I think about is how can I minimize the dose, not so much of the spinal cord at least right now, but how can I minimize it such that I'm still getting a good dose of
Yeah.
the tumor. So our colleagues at Mass General probably have been champions of this for decades, okay?
Okay.
Because they've had protons for a lot longer
Yeah.
than almost anybody in the United States. There's only a couple centers that have been around as long as they have, and actually I think they may have been the longest continuously running place. And so the approach that they've taken is that they've given some portion of the dose prior to surgery, and then we do the surgery.
Yeah.
And then we do
A follow-up.
follow-up further radiation
Yeah.
afterwards, okay? And then the other thing that they have done, and we've been doing in some of our cases, and I would like to consider that for you for because of that pressure on the
Yeah.
dura, is doing some radiation intraoperatively. And so we have a device that we've been using for how many years now? A number of years now. And I've done several of these cases. Actually, interestingly enough, I've done 2 in the last month, with one with Dr. Rose and one with one of his colleagues, where they take the tumor off, and we're worried about that area right on what's called the dura, the area around the spinal cord, of the tumor being juxtaposed to it and having cells left behind
Yeah.
right in a touchy area, and allows us to come in while you're in the operating room. So while that area is
Like a
exposed.
spot treatment.
Yes, but the spot treatment is actually using what's called a plaque, and the plaque is like a thin piece of plastic,
Mhm.
usually smaller than this, just a few millimeters in size,
Mm-hmm.
and it's flexible, so it allows us to bend it, and
Yeah.
so you can literally kind of
Protect
bend it.
that area.
Well, no, you bend it to kind of fit right around the
Okay.
area of the dura. Okay, so it's like it's not like this because this is too rigid,
Yeah.
but it's like this.
Similar
Allows-
to that,
Similar
yeah.
to this allows us. Now it's obviously not that big, and we actually measure the size we're going to use. Dr.
Mm-hmm.
Rose and I sit down. We figure out what the right size is for the area where we're worried about the tumor being in contact with the dura.
Mm-hmm.
Now, what happens is when they take this tumor out, okay, the dura has
Just expand.
expands
yeah.
back out. Expands back out to the size it was. So we wrap that stuff around the edge of it. And the nice thing about this is it allows us to give a dose to 1 millimeter. So
Wow.
that's not very far away, but it doesn't. And what happens is if this is the normal dura with
Yeah.
this fluid falling around the spinal cord, and the spinal cord kind of sits, if you will, virtually in the middle. It's floating in this sea of cerebral spinal fluid. Okay,
Yeah.
so this is the fluid. Okay, and then we put the plaque on the outside, and if we're only prescribing to 1 millimeter, that's right here.
Mm-hmm.
This is more like 5 millimeters away. So the spinal cord gets very little dose. Okay. The fluid's not a problem getting dose.
Yeah.
The surface is actually really what we're trying to treat here.
Yeah.
So this allows us to give a very good dose right in the operating room to the area of highest risk. So as I see it, the radiation kind of has 3 prongs to it: the initial radiation before surgery, this part in the operating room, and then further radiation after the surgeons remove the tumor.
Okay.
Okay. Now, one of the things that we have to orchestrate, number one, is we have to orchestrate the ordering of this plaque, because these plaques are specially ordered for each patient.
Okay.
They're one-time use. They're ordered for each patient. And so I have to make sure that we know exactly when the surgery is going to be and order that in preparation for it. But also the preoperative radiation isn't a long course. It's usually only around 11 treatments, okay? And we like to have the surgery relatively soon after that. So I didn't look to see, but one of the things that we need to do is we need to find out when they're planning on doing surgery. Have they talked at all about surgery?
Like soon, like in the next week, this end of this week or next week.
Okay, so that's not going to be feasible then to do the preoperative radiation, because we need 11 days of treatment.
Well,
So-
I mean,
okay, yeah.
You would have to verify with that.
Okay,
with-
right. So that's why I
with
say
Krause.
what I need to do is it's not just Dr. Krause, it's Dr.
Yeah,
Rose and Krause,
yeah.
and it's their surgery days. And my guess is did Dr. Rose talk about it being done all at one surgery, or did he talk about doing it at 2 surgeries?
So far, as I've been told, it's one
surgery. Okay.
So,
Because sometimes they do it as what we call a stage procedure. They do half part of it one day and part of it another day, but this is their ballywick, so I don't want to.
yeah, you'd have to verify with
Yeah,
them,
have to.
so.
So I need to talk to them about what the timing is that they're talking about,
Mhm.
and then we have to prepare, the plaque, but we also have to prepare the preoperative
Yeah.
stuff. So when we do radiation, before we start radiation, we do what's called a simulation or a planning session, and the planning session involves putting you in a position that we can reproduce day to day. So we have to have you very still and very immobilized.
Yeah.
Okay, it doesn't mean we're wrapping you in a body bag,
Yeah.
but
I've seen that in your book. It's like you wrap a thing over my face.
Right.
Yeah.
so the question is, will we want to do that with you laying on your back or on your front? And the ones I've done for the lower thoracic, or for the thoracic spine and the lumbar spine, we've had the patient lay on their front.
Yeah.
Okay, but this is a little different because it's kind of at that juncture of neck and
Yeah.
thoracic. So I need to talk to a couple people to figure out
Sure.
whether we can have you lay on your stomach or your back. But that either way,
Okay.
when we do that, we would create something that's going to immobilize you. It might be a mask
Yeah.
that comes over your back and shoulders to hold that area.
Centralize that radiation.
Well, it's to centralize you,
Yeah,
really, not
yeah.
the radiation. And then we do a scan in that position to
The CT scan.
CT scan in that position to identify where we're going to treat and identify the normal structures
Mhm.
that we're going to avoid.
Mhm.
Okay, so then what happens is after that scan is done, I go to work outlining, here's the tumor, here's the normal structures, and then we would use things like your MRI, and I might actually even do another MRI, but just in that position, a more limited MRI. But I have to kind of see, it depends on what position we're going to put you
Yeah.
in. Okay.
Did they put that tattoo thing on me?
Well, if we use a mask that comes down over your shoulders, we actually don't have to use a tattoo
Okay.
because we can mark right on that
Okay.
mask.
All right.
So part of it depends on which position we're going to put you in and how we're going to do
Okay.
that. Okay.
Sounds good.
So yeah, the tattoos are like
It's like
a needle poke,
Yeah.
and it's a really small little mark. So
Okay.
most of the time people can't even identify them
Okay.
afterwards.
All right.
In fact, we've had dermatologists say, "Oh, you have a mole here. We should take it out," and it's a tattoo. So yeah. And then once we do that planning session, then there's a timeline between the planning session and the start of the radiation. Depending on what Dr. Krause and Rose are thinking, if they think, depending on their timing of what they're proposing, will depend on how I want to give that radiation preoperatively. So with protons, which would be my favorite approach,
Yeah.
I need at least a week turnaround time.
Sure.
And that's not just for my time, that's actually for the planning time,
Yeah.
because I do my work pretty quickly, but then the people who do the planning have a lot of detailed work to figure out the plan to get the optimum dose to where we want it
Yeah.
and not treat what we don't want to treat. If we don't do that, if we do photon radiation, usually the planning turnaround is a lot quicker, just because we've been doing it for decades and decades and decades. So, it's a
Mhm.
lot quicker turnaround to start a patient on treatment. So that's why I need to talk to those two
Sure.
gentlemen to figure out what is our timing here,
Yeah.
and that's crucial to this.
Okay.
Let me see. After surgery, usually there is a time lag also to recovery
Yeah.
before we start the radiation. And that can be anywhere from 4 to 8 weeks time frame. And what I do is I have a discussion with Dr. Rose and Dr. Krause about healing and when do they think it's optimal.
Yeah.
So,
Yeah.
okay.
I get it.
So let's talk about side effects, because that's the next thing. Okay,
Okay.
so I group them in two categories: short-term and long-term. Things that happen during and shortly after radiation, and things that happen months to years down the line. Now, short-term, fortunately, most people tolerate pretty well. The preoperative radiation, the shorter course treatment, most patients are going to have minimal, if any, symptoms, because it's only 11 treatments and you're done.
Yeah.
Okay. The longer treatment afterwards, you're more likely to have side effects. So they can be skin reaction, like a mild or moderate sunburn in the
Mhm.
radiation field. Could be a little bit of fatigue. Of course, if you're coming after surgery and you're tired from the surgery, that's going to add to that in the scheme of things. If we're able to use protons, which I'm very hopeful will be the case, that should minimize the dose to things like your esophagus, your swallowing tube.
Yeah.
Okay, and so the risk of having
It's like a
difficulty with swallowing, or even short-term or even long-term after treatment, so that's good. The protons would help minimize the dose to the lungs, so the risk of long-term lung injury should
Yeah.
be small. What you would notice would be that the tissues that get the radiation, the tissues that we are treating,
Yeah.
are probably going to have a fair amount of scar tissue form in them, just like the surgery causes scar
Yeah.
tissue. So what does that mean to you? That means when you feel that area, it feels thicker, tougher, more leathery, if you will.
Yeah.
Now, okay, that's a feel, that's not a big deal. But what it does do when you have that is that it also does things like limits your
Yeah,
ability
yeah.
to do this because it pulls.
Yeah.
Now, that being said, my guess is they're going to be putting in,
They're doing plastic surgery, and they're gonna. They said potentially move a muscle from my back to
Okay.
that void.
okay,
So.
but did they talk about rods?
Yeah, they're gonna fuse my neck.
Okay, so when they fuse the neck, you're going to lose that range of motion anyway.
Yeah.
Okay, so at least some of it. Okay,
Yeah.
you will have some range of motion, but it will not be what it is
Yeah,
today.
yeah.
Okay, so what I'd say is, even if you didn't have the rods, the radiation would help limit
Yeah.
that as well.
Mhm.
So it's going to be hard to separate how much is from the rods and the surgery versus
Yeah.
the radiation.
Yeah,
So this is kind of an overall, I should say, not radiation effect, treatment effect.
Mhm.
Treatment meaning the total treatment. So the tissues there are going to be stiffer, in general compared to
I get
before. With the use of protons, like I said, I would expect very minimal problems in terms of other structures. Now, there's one other thing that I need to tell you, and that's that like I said, we think the protons are a slam dunk. This is what we definitely should be doing in this situation
Mhm.
for multiple reasons. Like I said, the normal tissue doses, your young age, all those factors. There's one obstacle that gets in our way sometimes, and that obstacle is called insurance companies. So what we don't know right now is, what is your insurance company going to tell me when we say we want to use protons? Okay. Now, I'm very hopeful, because there's a lot of data with chondrosarcomas of the spine that this is going to be easy. Because, like I said, there's a lot of data, especially from Mass General Hospital, that shows that this is the best way to go with these.
Yeah.
So I don't think it's going to be a problem, but I don't know 100%, because everybody's insurance is different.
Yeah.
Until we kind of jump through that hoop, we don't know.
Is that something that Mayo checks? So?
Yes,
Okay,
yes.
so
So what
before you
happens
do-
is, when I put in my request
Yeah.
for the appointment, for the simulation appointment,
Yeah.
they see that I want protons, and then immediately it goes to this gentleman who works on patients' insurance and gives me a note saying, within whatever period of time, yep, checked with insurance, no problem.
okay.
Or we have to do
Yeah.
a letter of medical necessity, or I have to do a phone call, or
Yeah.
whatever. Now, sometimes what happens is, even despite letters and phone calls to their insurance company, I still get kickback that says no. I am like I said, this is one of those indications that I don't think is going to be a problem, but
That's something that
You don't know until you
Yeah.
get there. So let's think positively, and I
Yeah.
think there's a very good reason to believe that this is not going to be a problem.
Okay.
But I have to at least mention it because sometimes that causes delays and things,
Yeah.
and that's why I need for you to know
Sure.
about that. Okay. Let me see. So I'm hopeful with protons that we're not going to have issues with your esophagus. We're not going to have issues with your larynx. We're not going to have issues with your lungs. All those kind of things.
The
We're gonna
spinal
make
cord, no, yeah.
Right. The spinal cord is going to be getting some dose of radiation.
Mhm.
There's no way of avoiding that.
Yeah.
The tumor is all
Yeah.
around it, so
Yeah.
there's no way of avoiding it completely. What we just have to do is we have to keep it to a safe dose. And
Yeah.
I think that's very feasible, and protons will allow us to do
Okay.
it in a better way.
All right.
Okay?
Makes sense.
Okay.
It's a lot to take in, right?
Yeah, it
Yeah,
is.
that's been a
Yeah.
lot for me to
Yeah.
take in.
Yeah, not kind of what you expect doing this year, I'm sure. Questions?
Not really. I mean, I'm past the shock and awe stage, and I'm just ready to get this over with.
Yeah, move
Yeah,
forward.
Move
Okay.
forward in my life.
So here's what I need to do is I need to talk to those characters about the timing and a little bit about the CRA question and let them and ask them what the timing is for them.
Yeah.
And then once I hear from them, then we're going to get set up with the planning session and go forward.
That
Okay?
sounds amazing.
Okay.
So,
I wish I could tell you I could do that today, but I think my schedule is already full today, so I can't even
That's
try
fine.
to add it in today. So
I get it.
so I'll let you have to go home today. I know you've been doing a lot of driving back and forth.
Yeah, it's.
So
I was trying to do it tomorrow, but I get it. I totally get
There's
it.
one
so.
other thing that I should tell you is while you're here getting treatment, you don't have to be driving all the way back and forth if you don't want to.
Okay.
Maybe somebody's already mentioned to you that we have what's called a hospitality house. It's called the Hope Lodge. It's an
Okay.
American Cancer Society facility,
Okay.
and it's for adult cancer patients who are going through treatment.
Okay.
It allows them to stay there. It's about a block and a half from here.
That's
and the
free of
charge is
charge?
it's free.
Wow,
It's
that's
free,
perfect.
yeah. So here's what happens is when a patient is ready to start treatment, then we put them on the Hope Lodge waiting list. And the waiting list, then as soon as the room's available, you get in.
Okay.
So it's not a question of getting in, it's a question of when. That's
Okay.
the part that I can't control because it's a
Sure.
matter of where you're on the list, and that list varies on how long it is.
Okay.
Now, the preoperative radiation, that's a shorter course. I'm hopeful you would still get in, but it may be a week, so maybe halfway in before you even get into it, in
Yeah.
the scheme of things,
Yeah.
just so that you know. With the longer course after treatment, there's no doubt you'll get in and you'll be here for that time period.
Okay.
There's a little flyer on the wall right behind your girlfriend there that
Yeah.
you can pick up that talks about it. And
Okay.
we'll give
Is
you
that
some
that house across from Ronald McDonald's house?
No,
Yeah.
no, no. So we have 3 hospitalities in the house. We have the Ronald McDonald for children, of course. We have the Gift of Life Transplant House for people having transplants, and then
Oh,
we have the
okay.
Hope Lodge. So we have a lot of hospitality houses, but this one's specifically for patients exactly like you.
So before the surgery, you're thinking how many? Like, I know I can't hold it
11.
to 11. Okay.
11.
And that would be 11 days?
11 days,
Okay.
Monday through Friday. Yes,
Okay,
right.
all right.
Yeah.
Okay.
You'd be free on weekends if you wanted to go home and
Yeah.
visit family or whatever you can.
Okay.
Okay.
All right.
So let me do this. Let me make those phone calls. I'm going to step out for a minute and get my card because I forgot to bring it in with me.
That's fine.
And then if you think of further questions, you can ask
Okay.
them. Okay.
Sounds good. Well, I'm glad after talking to her, I guess the trip was worth it. So.
Yeah, it was.
Right.
Yep.
Yeah.